The following podcast is part of a certified educational activity titled Find the Targets, Treat with Precision, Modern Principles and New Advances in Biomarker-Driven Lung Cancer Care. Access the entire activity and complete the post-test at peerview.com/UTP860. Downloadable slides and practice aids are also available.
Hi, and welcome to today's CME done in partnership with Longevity and PeerView on targeted therapy in lung cancer. I'm Dr. Amy Moore, Longevity's Vice President of Global Engagement and Patient Partnerships. At Longevity, we have two main goals. The first is to improve outcomes for people diagnosed with lung cancer, and the second is to improve how people live with lung cancer. We know that optimal care for lung cancer is driven by precision medicine. And at Longevity, we define precision medicine as biomarker-driven care from pre-diagnosis through diagnosis, treatment, and potential progression. And we have programs and services along this entire spectrum of care. First, we have an extensive offering of survivorship and support services. These include our lung cancer helpline shown at the upper left, which is staffed Monday through Thursday from 10 a.m. to 6 p.m. Eastern, and Fridays from 10 a.m. to 5 p.m. Eastern at the numbers shown there. We also provide peer-to-peer support in the form of our Lifeline support partners and clinical trial ambassadors. Additionally, we provide a clinical trial finder so patients can find trials that may be relevant to their care. We also offer an extensive suite of patient education services. This includes our comprehensive Lung Cancer 101 website, videos, booklets on various topics, and questions that you can ask your doctor in the form of tear sheets that patients can take with them to their medical appointments. You can find all of our educational resources at the link shown here. This includes our comprehensive booklets shown on the left, which includes booklets on various stages and subtypes of lung cancer, as well as booklets on testing and different treatments, including biomarker testing, clinical trials, chemotherapy, immunotherapy, radiation therapy, and targeted therapy, both in English and Spanish. We also provide shorter, more digestible forms of this same information in the form of brochures and flyers, as shown on the right. So again, go to this website and you can access all of these materials. And now I'm going to hand it off to my colleague, Nikki Martin, who serves as Longevity's Director of Precision Medicine Initiatives, to talk more in depth about some of our targeted therapy offerings. Nikki?
Thank you, Amy. Hi, everyone. I'm Senior Director of Precision Medicine Initiatives at Longevity Foundation. We have something for everyone when it comes to biomarker testing patient education material, and we wanted to really hit on that for today's CME, since that was such a big focus. We think it's very important that patients understand more about this component of their care, and so we have the comprehensive booklets around biomarker testing that are written at an 11th or 12th grade level, and then also health literate materials on biomarker testing that are available in English and also available in Spanish. In addition to these materials, we recently launched a campaign called No One Missed. And this is a public awareness campaign aimed at Black and African American and Hispanic Latino communities to increase awareness amongst those communities to ask their provider for biomarker testing. And if it's not available through one provider, to seek a second opinion. In the coming months, we will start localized awareness activities in Atlanta, Philadelphia, Chicago, and Miami. And finally, the Longevity Lung Cancer Patient Gateways are custom-made gateways for people with specific types of lung cancer to find specialized patient resources, allow patients to easily access biomarker-specific information, and connect the community and experts. The KRAS, ALK, EGFR, and NSCLC gateways are currently online and available for your patients to access. And later this year, we will launch gateways for rare mutations such as MET, RET, and ROS1 in addition to a gateway for small cell lung cancer. We encourage you to introduce your patients to these resources for tailored information unique to their type of lung cancer. And finally, we thank you so much for participating in today's CME program on biomarker testing and targeted therapies. Longevity is here to support you, to support your patients. So please tap into our organizational resources. Thank you.
Welcome to this evening's peer review CME event. Thank you so much for joining us. It's great to see all of you in person, a lot of familiar faces, and certainly acknowledging all of those watching virtually, joining us through the internet. This title of this program is Find the Targets, Treat with Precision, Modern Principles and New Advances in Biomarker-Driven Lung Cancer Care. Certainly the field has been revolutionized during all of our careers. We're going to talk a little bit about that today, and I am joined by a very esteemed panel. For those that don't know, my name is Stephen Liu from Georgetown University, and I'm joined up on stage by three of the top lung cancer minds in the world. To my immediate left is Dr. Marina Chiara-Garasino from right here at the University of Chicago. Next is Dr. Ross Camage from the University of Colorado, and at the far end, Dr. Sanjay Papat from Royal Marsden in London. And I think it's no exaggeration when I say these three have not only contribute to many of the standards of care we now take for granted today, but have really shaped the field of precision oncology in lung cancer and beyond. I'm looking forward to today. And today's activity is not necessarily just a lecture or a regurgitation of the data that we've all seen. What I really want to do while I have the three of you up here is try to get into your head and understand how you approach precision oncology, how you make the decisions, and how you exercise the judgment that you do so well. So here's our agenda today. We're going to go over some of the gaps in biomarker testing, talk about how we act on those. And as I mentioned, we're going to go through how we approach targeted oncology, really get into the mind of these experts up here. How do we select our initial therapy? How do we approach CNS and resistance? And how we move these principles up into the earlier stages of lung cancer. I'd like to acknowledge Longevity as our partner. We know that patient education and engagement in care decisions is more important than ever. Clearly, all of these choices are shared decision-making models. There are more options. We want to really empower our patients to help make the best decisions for them. With us, Longevity is partnering with us in this program to bring in the patient perspective and to highlight the importance of having open conversations with the patients about the diagnosis, biomarker testing, treatment options, allowing patients to advocate for themselves. Please do access the supplemental Longevity resource compendium that's available with this program. You'll be able to download some aids that will make, I think, your practice easier, your patients' participation a lot easier. A lot of us have seen a graph like this before, and in our lifetime, we've seen the role of the medical oncologist really evolve, where not only are we responsible for making treatment decisions, but really the interpretation and the ordering of biomarker testing. The responsibility does not fall now on pathologists, it really does fall on medical oncologists, and so we're responsible for understanding what all of these slices mean. We've moved well past the difference between just non-small cell and small cell, between just histological types of cancer like squamous and non-squamous, and we now recognize that each of these slices represents a different biology. Each of these genomic alterations represents really a different cancer, and we finally have the ability to treat these cancers appropriately. And individually shown on the right is a long list of approved drugs with matched targets. That list continues to grow. There will be more by the end of the year, and it is hard to keep up, which is why we're going to ask some of our experts what they think. And while it's clear that biomarker testing drives the initial proper management of patients with advanced non-small cell lung cancer, we are not doing as great a job in testing. Shown here on the left is data from the MyLung Consortium. These are relatively recent U.S. data. And if we look at a relatively simple panel of EGFR, ALK, ROS1, BRAF, PD-L1, targets that we know about, targets where we have approved drugs and pretty straightforward tests, how often are we checking for all 5 of those? Less than half of the time. If we look at just EGFR, where we have multiple easily approved tests to look for EGFR, where we have many very effective drugs, where we need that information to make the right decision, we only test for EGFR in 76% of non-squamous lung cancer. That's here in the US. So 1 out of 4 patients is not getting biomarker testing. Marina, let me go to you. Since you've been here at the University of Chicago, is this what you're seeing in the US? And how does this compare to your experience in Italy?
Yeah, I think that we are not testing enough. The situation is very similar here in Chicago and also in Italy. And I think that the data presented last year in ASCO, they reflect very well the situation. So in about 50% of patients, we do just 4 tests, and only in less than 40% of patients, we are doing NGS prior to the first-line therapy. So I think that there is a lot of space to improve.
Yeah, certainly the case. We could do much better. And when we look a little closer at our testing rates and really some of the flaws in our testing, we can see that biologically, there's not much difference between different races. Shown here are data between Black and white patients with advanced non-small cell lung cancer. And what we see is the rate of EGFR mutation and ALK fusion is the same in Black patients and white patients, but our ability, our sort of performance in terms of testing clearly is not. What we saw in these data were Black patients were less likely to get tested, were less likely to get tested early, and were less likely to get full testing with NGS, despite really the opportunity to benefit from those same drugs. Ross, is this something you're seeing in Colorado? What can we do about this?
So one of the surveys that I found most interesting was if you ask people, do you do full biomarker testing? Most people responded yes. And then the second question was, do you think the other people in your practice do it? And they go, no. And so it's always the other guy's fault. And I think we have to take ownership of this sort of thing. So, I mean, we've been testing everybody for everything, but I think this reflects some implicit bias. It can't just be access to medical care, and we have to do better.
Yeah, absolutely agree. So a lot of room for improvement, and it really starts with all of us individually. We are now going to go to our first principle of biomarker testing, interpretation of results. And for that, we have a case that we can walk through together. I think it's a pretty typical case. A 50-year-old female non-smoker who comes to see you today for a second opinion. She's noticed a persistent non-productive cough, gets tested for COVID. That's negative. Given an inhaler, antihistamines, didn't get better. This should sound very familiar to us. Finally did an x-ray that showed a lung nodule. CT also shows liver metastases. We biopsy the liver, and that shows metastatic adenocarcinoma, TTF1 positive, PD-L1 50%, no driver alterations on standard reflex testing, minimal symptoms. As we expect, this patient is very anxious, is eager to start treatment immediately. They're offered immunotherapy from their primary oncologist, but you know what? Before they start, they come to see you for an opinion. Here are some of the details through the records. We have a PD-L1 expression of 50% with a DACO22C3 clone. We have wild-type EGFR, BRAF, and KRAS by PCR, wild-type ALK and ROS1 by FISH. This patient has relatively minimal symptoms, but eager to start therapy, and so I'll ask you to join with us. What are we going to do next? Are we going to agree with our colleague and say immunotherapy is appropriate? We have high PD-L1. We didn't see anything on reflex testing. We can stop now. We need to start immunotherapy. Do we start immunotherapy with send a liquid biopsy, maybe full NGS, and then switch later if we need to? Do we tell the patient it is important to wait for those results? Do we get a liquid biopsy? If that's negative, start immunotherapy? Or do we say we really need full results? We are going to order a liquid biopsy and comprehensive tissue-based next-gen sequencing. And if it shows a target, we start therapy. If we don't see anything liquid, we wait for tissue. Or I'm not sure. It's okay to answer that as well. And so I'll ask you to key in an answer now, and then we'll ask our panel their thoughts. But this is a situation I think we see a lot. Generally, patients, especially non-smokers, go through a long course from symptom to diagnosis. And Sanjay, do you feel like patients are often very eager to start therapy?
Yeah, I mean, absolutely. I mean, it's a really late diagnosis for most patients with never smoker. They're diagnosed often with asthma or something like that for a while. And so telling a patient, actually, we don't need to rush into anything goes completely against what they want to know. But it's really important that we have these discussions, that actually starting off with immunotherapy without really understanding the biomarker profile may not really be the best thing to patients.
Absolutely agree with that. And one of the things we can do to try to decrease the time while we're waiting is reflex testing. And reflex testing has pros and cons. Sanjay, can you walk us through what we mean by reflex testing?
Yeah, so reflex testing has sort of come about because, originally when we started molecular testing, it was the oncologist that was making the decision to test or not. And then testing has got more difficult. And so therefore the pathologists have started taking some ownership on this testing pathway. And the reflex testing is when the pathologist at the same time as making a diagnosis of lung cancer will also order the molecular testing. That has some great benefits because it can really truncate the time till we get a result, because the pathologist has already cracked on with that. And not only that, but the patient actually knows that the pathologist already knows that the patient may have 2 or 3 other samples in the lab and may choose not to use the sample that he's dealing with, but another one from a core biopsy, for example. So they know the best specimen to use, they can just crack on with it. However, the problem with this is that, it may be not appropriate for that patient. The patient may have a stage 1A lung cancer, in which molecular testing at that time point may not be appropriate for that patient. And, the oncologist may have a better understanding of what tests the patients need. A good example is a patient that's progressing, for example, on a TKI, when you're really interested, for example, in met FISH, not necessarily in a standard NGS panel where you can't tell. So I think there are pros and cons. Personally, I favor the reflex testing.
Right. We know that early testing is important. This is no longer this ivory tower exercise where we're learning about it. Really, it impacts how we treat patients from day one. We need that to optimize care. It tells us about the biology. We've seen some data, Ross, on certain tests, certain biomarkers predicting involvement of different metastatic spread or venous events. Is that correct?
Yeah. So we've known for over 10 years that, for example, ALK has a high spread of pericardial and pleural disease. And then most recently, we showed that the rate of peridiagnostic clots, sort of within 90 days of diagnosis, is influenced by the oncogene. So 40% of ROS1 patients will actually present with a clot.
So it tells us about the biology, tells us about prognosis. Most importantly, it guides initial therapy up front. It lets us choose targeted therapy. It lets us deselect immunotherapy. And immunotherapy is certainly an appealing treatment, is a transformative treatment. We see direct-to-consumer advertising, see a lot of billboards on Michigan Avenue about different immunotherapy drugs. I don't know if those are always there, but we know immunotherapy has not been very effective in driver-positive lung cancer. Shown here is really the immunotarget study from Julien Mazieres in France. And we see that for most drivers, some exceptions like KRAS, but for EGFR, ALK, MET, immunotherapy largely disappointing in the salvage setting. But not only is immunotherapy less effective, there are also some safety concerns with using immunotherapy in a driver-positive lung cancer. There's really the potential to do harm for our patients. Maria, can you sort of expand on what I mean by that?
Yeah, this was a very clear trial. The patients were EGFR mutated, PD-L1 more than 1%. The majority of them, there were PD-L1 more than 50. So this was the typical case that we see in our daily practice, PD-L1 more than 50 and EGFR mutated. And in this trial, there was pembrolizumab because they were PD-L1 high, and then patients were treated with EGFR TKI at progression. And the response rate for immunotherapy in these patients was about 0%. So we are treating patients without any efficacy. And if we look at the safety was terrible because we had in 14.3% of patients pneumonitis. And the same concept was not just for EGFR tyrosine kinase inhibitors, but we saw the liver toxicity for the ALK inhibitors after the immunotherapy. And again, recently published also the hypersensitivity reaction to selpercatinib in RET positive patients. And as you can see, it is 11.2% compared to just 2.8% in no prior immune checkpoint therapy. So the response rate of the immunotherapy is very low, if not zero, and you can risk a lot of toxicity, and so then you have to stop the drug during the treatment.
Now, to me, this is a very new principle in oncology, because generally what we're used to in practice and trials, we give chemotherapy, it's not working, we stop, and we wait a little while, and we have a fresh slate. We can start over. But that's not true with immunotherapy. When we give immunotherapy first, it changes the efficacy potentially and the safety, definitely, of everything we give after. And so if we give a TKI first, generally pretty safe. But if we give a TKI after immunotherapy, it's different. Ross, do we know why this happens?
We don't. The best way to remember it is actually an expression from Jack West, which is poisoning the well. So you've got the patient who's a never smoker you think might have a driver oncogene, and if you give immunotherapy with that first cycle, you have set yourself up for failure if you then have to get them on a TKI later. One of the things that seems to come out is it seems to exaggerate the pre-existing side effects of the TKI. So if EGFR inhibitors cause pneumonitis, that becomes exaggerated with immunotherapy. If they happen to be causing transaminitis, that gets exaggerated with immunotherapy. We don't fully understand why.
Clearly happens, and it seems to be across drivers, not something we want to explore. That really is why the order, the sequence matters. And if there are some patients that need treatment today and we don't have results, in those settings, I think we all agree that we start with chemotherapy because we can walk back from chemotherapy, but not necessarily immunotherapy. So biomarker testing is essential, not just to identify the potential for targeted therapy, really to avoid immunotherapy, which is ineffective and which makes the proper therapy much more dangerous. There are different ways to do biomarker testing, and I want to talk a little bit about liquid biopsy. Sanjay, what do I mean by liquid biopsy?
Yeah, so liquid biopsy is a sort of colloquial term that we've used to talk about circulating tumor DNA testing. And circulating tumor DNA testing is a part of the cell-free DNA that we can evaluate from the plasma from a patient. And different tumors shed their DNA into the plasma at different rates. High-grade tumors more likely to shed into the plasma. Patients with bone mets, perhaps liver mets, more likely to shed into the plasma. Patients with brain mets, less likely to shed into the plasma. And you can actually sequence across these small fragments of DNA from the plasma and infer whether the DNA fragments you identify are from the tumor or not. We have to remember there are 3 genomes in the plasma that we're testing: the tumor genome, the human genome, the germline, but also the leukocyte genome, the CHIP genome. And that then goes on to give us some benefits and some disadvantages, because often, we're starting off with tumor tissue genotyping, which has been our gold standard for many years. We know that it's relatively slow, particularly if we're doing large panel NGS. It's quicker if we do PCR, but then we're missing a few variants. We know that the sensitivity is very good, and we know that if we find a variant, we can believe that it really is the actionable variant. We know that the specificity is very good, and it's unlikely that you're going to report something as somatic when in fact it's germline, and the cost depends on the provider. With plasma ctDNA testing, things are slightly different. It is much more convenient. You can schedule the patient to come up for a blood draw at any convenient time point, not necessarily at the point at which the biopsy takes place. It's much quicker than waiting to order the tissue to come out of the pathology archive, for the block to be cut, to be sent to the third party, to then be analyzed, to the report then to find its way back to the person that ordered it in the first place, who's not the person that's actioning on the results. It usually comes back to the person that has ordered it in the first place. Sensitivity, however, is problematic, and it's much lower sensitivity in general than we find with tumor tissue testing, specifically for variants like amplification events and also fusion events, which are more problematic to detect with plasma genotyping than tumor genotyping. And specificity, whilst it's really very good for driving mutations, you do sometimes find these false positives called CHIP variants, which are variants from the white cells, which you just need to be a bit careful in interpreting, and the cost depends on the provider. I think both are complementary. You just got to understand the pros and cons of each particular approach.
Yeah, agreed. And, they can be helpful in finding things like fusions. We know fusions are critical to find. Noted here, a different kettle of fish, little word play. I would encourage any trainees that have the ability to go to a pathologist when they're doing FISH. It is an eye-opening experience in how labor-intensive it is to see a pathologist just sit there and count cells. And it is a little scary to me at how inaccurate FISH can be and how user-dependent it is. Now we use NGS largely to find many of these fusions, but how you test for fusions matters. And so we need to understand how that matters. We need to understand the limitations and the details of the test that we're ordering. So not enough just to order a test. We need to know what test to order. Ross, which of these fusions are challenging, and can you tell us a little bit about DNA versus RNA?
Okay, so when you're using next generation sequencing, what we're talking about is the starting material. So it's not DNA versus RNA, it's DNA plus or minus RNA. When you sequence through DNA, you've got the introns in there. And so it gets harder for certain gene rearrangements, which may have a huge gap between those two things, which are brought together in the final transcript. They can also have multiple repetitive sequences. They can have areas where primers don't bind very well. And so by using RNA, you kind of cut out literally the middleman. You say, okay, you've already processed this RNA. Now these two epitopes are next to each other. You only need primers really on one of the epitopes and you can sequence through. So your pickup rate goes up. And the reason it matters is if you're just using a DNA-based next-generation sequencing panel, you will find a fusion or a mid-exon 14 some of the time. And you'll go, I found one last week. What you won't know is the 10 that you missed. And so the pickup rate when you use an RNA-based sequencing panel in addition to a DNA-based sequencing panel is sometimes double that for specific oncogenes.
Do you ever see this, Ross, where someone will come see you for a second opinion? I'm sure you get many. They've had DNA-based next-gen sequencing, and you'll find something on RNA afterwards?
Yes. I mean, it's one of the things that makes you feel like your job is worthwhile. So the patient comes in, they're told they're marker negative. And the first question you're going to ask there is, well, what didn't they test you for? Or how did they not test you appropriately? And so this study that you're showing here from MSK took patients who were described as driver negative by a DNA-based panel. They had an RNA-based panel added in afterwards, and 15% of them, they found a potentially actionable abnormality, mostly abnormal gene fusions.
Ross, I take it from your enthusiasm here that you're employing RNA-based NGS in addition to DNA?
Yeah, so we have a commercial panel. It's made by Archer, and then we're doing both a DNA and an RNA-based extraction.
I'm curious for our colleagues here in the UK, is RNA sequencing available?
Yeah, it is actually. In fact, the government have got a centrally funded 7 genomic hubs within England, and there's a panel of 7 actionable genes, and the recommended testing is a combination of DNA and RNA. It's not that well implemented, but that's what's meant to be going on. And actually, in many of the labs that do it, that's working very well.
And Marina, in Italy and here at University of Chicago?
Yeah, here at the University of Chicago, we have the RNA panel. And in Italy is less frequent. Unfortunately, is only available in the big cancer centers. So I believe that at least in my previous country, we need to refer patients to big centers, in particular if they are never smokers.
And I think it's really the responsibility now of us, of oncologists, to know the panel we order, is it DNA and RNA? We need to know those types of specifications. That's really different from, I think, the time when we were training. And it really is a new responsibility for medical oncologists. So if we go back to our case, as a reminder, this was a non-smoker female with very high PD-L1 expression, no drivers on PCR and FISH, eager to start therapy. Her oncologist recommended immunotherapy. What would you do here, Sanjay, when you see this situation, high PD-L1, negative PCR, negative FISH? What's your practice?
You know, we clearly need to genotype this patient more extensively to find the driver.
Yeah, we have a very high suspicion that there's something that's going to influence our treatment and the risk of sort of choosing the wrong therapy. And there really is a wrong therapy in this setting. And so if we go back to this question, I'll ask the audience again, PD-L1 high, we see no drivers by PCR and FISH. What are we going to do in this setting? A patient that doesn't have too many symptoms. Do we want to proceed with immunotherapy because PD-L1's high? Do we want to wait for a liquid biopsy? Or sort of that bottom answer, do we want to just wait, send off liquid? If liquid's negative, wait for the tissue. Only when full liquid and tissue are negative do we proceed with immunotherapy. So we'll let everyone answer here.
So one of the red flags is if you have a never smoker and have a PD-L1 of 100%. So that is telling you that that is not the perfect patient to give to. That is the patient who has a driver oncogene, because often PD-L1 goes up downstream of many driver oncogenes. So super high PD-L1 in a never smoker is actually a big red flag that you should not give immunotherapy, at least in my experience.
It means something different. And a lot of people say, I see very high PD-L1 100%, and I see a ROS1 fusion, which is the winner. And consistently, the target's the winner, right, Ross?
Yeah, every time.
Every time. It just means something different in that setting. In fact, the median PD-L1 expression for ROS1 is north of 90%. So it just means something different there. I'll encourage everyone to go to the website listed here, www.longevity.org/booklets. You can print out these booklets or direct your patients there. These are patient biomarker testing handouts that really help us explain what biomarker testing is, and it can really make things a lot clearer for patients and certainly help us out in the clinics. They are available in Spanish and for health literates as well. Acting on biomarker results, here we're going to talk a little bit about granularity. And I think these are important points because, again, the role of a medical oncologist really is changing. We really are responsible for being a molecular oncologist. And for a large part, we didn't really get that training. And so we need to sort of pick up as we go. We know that testing is needed to optimize care. We know that it guides initial therapy. We know that we need NGS and that there's a difference between DNA or DNA with RNA. But even beyond that, we need to know exactly what alterations we're looking for. And I think a good example is MET. And so, Ross, if I tell you I have a patient and I want your input and they're MET positive, what does that mean?
It means you need to go back to school. So it's not enough. So MET is, and if you don't know about it, it gets more and more complex every year. So MET can function as a driver oncogene through a MET exon 14 skip mutation, through MET amplification, which can be defined and categorized in different ways through super rare MET fusions. And if that wasn't crazy enough, you're going to start to learn about MET protein expression because it's a marker for antibody drug conjugate activity. So yeah, MET positive, that's not enough.
And Russ, when you say MET amplification, would that be enough?
You know the answer to that question. So no. So amplification is a continuous variable. So, you've got one from your mom, one from your dad, you've got 2 copies. Well, what if you have 3? What if you have 30? Then the other thing is, what if that is increased, but everything else on the same chromosome is increased too? So, for example, EGFR is on the same chromosome 7. That's high polysomy, multiple copies of chromosome 7. Does that mean the same versus your chromosome is still there, but just that one region where MET is has suddenly been amplified? So the former is called high polysomy. The second is called true amplification. It's not that one is right and one is wrong. They both increase the chance that you will have MET as an actionable abnormality, but the exact level in each of those scenarios differs.
And I am just struck by the granularity that we're expected to be responsible for. And we really do need to stay up to date with how these impact the biology and how they impact our treatment decisions. We're familiar in oncology with HER2. You see HER2 in breast cancer. It really guides therapy, one of the early targets in oncology. HER2 positive breast cancer managed a certain way. Marina, HER2 in lung cancer, mean the same thing?
Yeah, see, what you said is perfect. So we are not in breast cancer, and we have 3 situations: the amplification, the overexpression, and the mutation. For the amplification, the results are really controversial, but we have good results for HER2 mutation. So don't consider lung cancer if HER2 is overexpressed like breast cancer, because we are in a totally different situation.
So the tumor type matters, different alterations in different cancers. It's much more complicated, and we really can't say HER2 positive. We would want to say HER2 mutant, HER2 mutation, and which specific mutation is present. And we know that there are many different mutations, mostly within exon 20. All these details sort of matter. But even saying mutation might not be enough, right, Sanjay? So if I told you KRAS mutant lung cancer and I want your input, is that enough detail?
No, definitely not. I mean, it used to be, but actually, like everything in the world, we move on. We get greater detail. We understand the biology better. We understand the biology better. We can understand the therapeutic choices that we need to make for our patients better. And in the world of KRAS, we know that KRAS is a driver variant for lung cancer since about 1987. But now, with the advent of G12C specific inhibitors, it's really important to know the specific mutation within KRAS that your patient has. And you can see from this slide, there are many different types of KRAS mutations. KRAS G12C is the most common mutation seen in lung cancer, accounting for about 13% of all lung adenocarcinomas. And we have, very good KRAS inhibitors, which are now available.
I realized that KRAS must have the same timeline as Top Gun movies. So first version comes out in mid-1980s, and then the second version comes out in the 2020s.
And a dynamic treatment field we now have as a result. I mean, if I can go on from that, we have the...
Sorry to interrupt.
We can have the data from the CodeBreak study. I mean, you'll know this is the data from sotorasib, which is a specific G12C inhibitor, which means if you found a G12D, you don't want to give it. If you found another KRAS mutation, you don't want to give it. If you found G12C, you do want to give it. And this drug is now licensed and approved and reimbursed in many parts of the world. And this is the registration data set from the CodeBreak 100 trial, in which 124 patients with relapsed non-small cell lung cancer metastatic were treated with the drug sotorasib at 960 milligrams a day. Now, this is a very interesting group of drugs because it's not really the same as a receptor tyrosine kinase inhibitor that we're used to dealing with, like ALKs and ROS and EGFRs. KRAS biology is really complicated, but I'm going to make it simple for you. So these drugs trap KRAS in an inactivated state, in an off state. But the biology is complicated, so we get different types of outcomes than we have expected to see compared to our RTK signaling. And so what we see here is a response rate of about 37%, which for me, I think is really, really very interesting, because actually our taxanes, which we're generally using in this type of setting, have response rates of about 10 to 20% at most. And we look at progression-free survival, we're seeing that around 7 months or so. If we look at overall survival, that's really, much better than we would typically see, because this is generally a poor prognostic oncogene as well. These patients have bad disease in general. So 12.5 months, pretty good in that setting. Now, we do have some safety issues. We do need to bear in mind this drug, can cause problems with diarrhea, GI toxicities, with nausea, with transaminitis. And if you've primed your patient with IO beforehand, you may be able to trigger some liver tox with that. So you just have to bear in mind that the tox that you get may not be drug-related entirely, may be related to IO as well. And at this meeting yesterday, we heard the data from Mirati, where the Crystal-1 study reported with the covalent G12C inhibitor adagrasib, which is another off inhibitor trapping a KRAS G12C in the inactivated form. And again, we see very good activity, very similar, I would suggest, to what we've seen with sotorasib, with response rates of around 40%, progression-free survival just over 6 months or so, and treatment-related adverse events in the same sort of ballpark as we've seen with sotorasib.
Yeah, these data published in the New England Journal yesterday, fresh off the press. And what I see a lot, I'm not sure if you do as well, is really a lack of understanding of what G12C means. It means that at position 12, amino acid G turns into C. And that C, that cysteine, is where this drug binds.
Yeah.
And I see a lot of patients come with opinions where they'll have a G12D or G12V. And I'll say, well, 40% response rate with sotorasib for G12C. For G12D, maybe it's 20%, maybe it's 10%, but it will be 0%. And so really it is, these details matter quite a bit. We're responsible for that. EGFR is another one. We're familiar with EGFR mutations. Now you have to be familiar with what specific mutations you're looking for. We know deletion 19 and L858R, leucine to arginine at 858, L858R mutations. These are our common sensitizing mutations where we have osimertinib, erlotinib, gefitinib, afatinib, dacomitinib. But for atypical mutations, we have different drugs approved. And for exon 20 insertions, we have different ones as well. And so that brings us to our next question here. What is the clinical significance of an in-frame exon 20 insertion detected in tumor cells of a patient with advanced lung adenocarcinoma? So an exon 20 insertion, A, this mutation predicts response to a first-generation TKI, erlotinib, gefitinib. B, predicts response to amivantamab, mobocertinib, poziotinib. Or C, the mutation is not targetable. Chemotherapy is our best option. D, mutation is not clinically relevant. That's a benign polymorphism, or not sure. I'll ask you to key in your answer here. Let's learn a little bit more about exon 20 insertions. Marina, can I ask you to talk us about this specific class of alteration?
Yeah, this is a small group of patients, and they have specifically a mutation in the exon 20. And we know them very well because in the past they were very resistant to the first and the second generation tyrosine kinase inhibitors. So we were used to see insertion in exon 20, and we knew very well in the past that we didn't have to give gefitinib and erlotinib. And as you can see here, also the progression-free survival was very low because the activity was about 0. And we know also that these patients, they have a worse prognosis compared to the other, because also they didn't respond very well to the first and the second generation TKI. They are an heterogeneous group of patients. Again, you can see that there are a lot of variants. And we have results for new drugs. And you can see on the right that there is also a different IC50 in the side lines. And there is some activity that personally I think is really low for afatinib. What it is really important is that this mutation in 2022 is targetable. And again, like before, we have to diagnose this mutation. And we know that if we just use the PCR, we can miss 50% of cases. So I think that, again, coming back to the previous discussion, we have to do the NGS also to identify also the exon 20 insertion. And the reason is that in 2022, we have drugs for this mutation. We saw the results of Osimertinib last year, and we saw also the results of Mobocertinib, and there is also Positionib, and other drugs are coming. So you have to remember that although it is rare, this is a potentially targetable mutation. Osimertinib is a bispecific antibody targeting both EGFR and MET, and Mobocertinib is an oral drug with an EGFR tyrosine kinase activity.
And I've found these to be very frustrating, for years before these drugs were approved, because you have a female, never smoker, younger, you have that phenotype where you're really suspecting an alteration, you hold off on therapy, you send off NGS, it comes back, you see EGFR, and your heart leaps, and then you see exon 20 insertion, and it just falls, because we're not going to get that benefit from immunotherapy because of the EGFR, but we know that great drugs like Osimertinib or a lot of them, they're not going to be effective either. And it really left us without any advances, just chemotherapy, the same chemotherapy we've been given for decades. And so we were really depriving patients of that option. We know the target's there, but we had no way to sort of target that. And that changed last year with the approval of 2 drugs. Ross, do you want to walk us through a little bit of these targeted drugs in EGFR exon 20?
Yeah. So Amivantamab, I think was a dark horse. I don't think anyone expected it to work here, but it did, and they ran with it. So it's got about a 40% response rate. I don't have the toxicities on this slide or the next slide. I don't know why. Well, it also works, it's a MET EGFR. It also works in MET exon 14 skipping mutations. We saw that data at this year's ASCO. But one of the interesting side effects with Amivantamab is something like 2/3 of your patients on day 1 will have an infusion reaction, and then they will never have one again. So you just have to tell the patient, hi, we're going to start AMI today. It's going to be a bad day. And then you're good. It's one and done. So it's a really nice infusion reaction. It's not like playing Russian roulette the other times. You also get some rash and some fatigue, but it's not too bad. Mobo, on the other hand, has a kind of similar, if numerically slightly lower response rate in the kind of high 20s to sort of low 30s. It has no CNS penetration. AMI, we're not aware, has any CNS penetration. Mobo definitely has no CNS penetration. That's an overt liability. And it has quite a lot of toxicity, a lot of diarrhea, a lot of rash. Positionib, I think, is even worse. Mobocertinib, I view as a proof of principle drug. We have a TKI that will work in exon 20 insertion. The whole goal is to find one with a wider therapeutic window that hits EGFR wild type nowhere near as hard as it hits the exon 20, and to get one that has CNS penetration.
We've got new drugs coming as well. We heard about some at our oral presentations at ASCO later. This clearly is an area where we can address this target, so it is changing. Important to find these exon 18 mutations, another different alteration within that EGFR gene. We know Neratinib is an emerging treatment option. Shown here are some early data from the Summit trial showing some promising early efficacy in a relatively small data set for Neratinib, but really just highlighting the granularity, the different options we have for different mutations, and all of these details really do matter. So let's go to this case. A 62-year-old male, former light smoker, has a right-sided lung mass on a calcium scan for his heart. We do staging, no mediastinal involvement, nothing distant. We have a stage 2A lung adenocarcinoma. For a stage 2A, we're going to offer chemotherapy. So this patient gets 4 cycles of adjuvant cisplatin pemetrexed. 6 months later, nothing. 1 year later, we now see multiple bilateral lung nodules. So lung cancer, a very difficult cancer to cure, even in early stages. This was relapsed within a year. We do a biopsy, recurrent lung adenocarcinoma. We have a liquid biopsy that shows an EGFR mutation confirmed on tissue. Here's our EGFR results shown there. EGFR V774_C775, INS, NPHV rolls off the tongue at 1.4%. What are we going to do in a case like this? And so, Ross, how are you going to interpret these results?
Well, so this is an exon 20 insertion. Hold on, let me check I read it right. Yep, exon 20 insertion. There you go. And we're going to ignore the other results because they're not going to change what we're going to do. And I think here we know we have these targeted drugs, amivantamab and mobocertinib. Technically, both of them have a second-line license, and maybe that's appropriate when you only have a 20 to 30% response rate. And so for this patient, I would actually start them on chemotherapy. I probably would avoid the immunotherapy so that I didn't poison the well. And then when they progress, I would be thinking about these other agents. I would be very cautious if the patient had brain metastases to recognize that I have limited options for controlling that with a drug.
All right. Now, we'll see if our audience agrees or disagrees with Ross Camage. What is the significance of an in-frame EGFR exon 20 duplication mutation detected in a patient with advanced lung adenocarcinoma? Does it predict response to a first-gen TKI, to amivantamab and mobocertinib? Not targetable. Chemotherapy is the best only option, or not relevant at all, a benign polymorphism. So I'll let people key in their answer here. If you see a result like this and you're not quite sure what it means, what are the resources we have? Can you call someone to get help? Can you phone a friend to sort of get someone to walk you through what those mean?
Yeah, I think that if it is available in your center, the molecular tumor board can help. And I think that in this case, which is the duplication mutation, so maybe we are not so familiar with the with this wording, we can go back to the pathologist and ask.
Yeah, so it's not meant to be overwhelming. When you get a molecular test result, sometimes there's a lot of letters, numbers you don't understand. Call any of these people up here, certainly, but you can reach out to the company, you can reach out to other experts. There's no shame in asking for help if we don't know what these things mean. They really do make a difference. So now that we know about testing, we're going to send NGS, we're going to think about liquid, we're going to think about RNA. What do we do once we have these biomarkers? How do we use that to choose our initial therapy? What are the features that we're thinking of? We certainly have many options. We have the possibility of chemotherapy versus targeted therapy. If we're choosing targeted therapy, how do we choose our drug? So when we look at these data, we see these New England Journal articles, we see differences in response rate, PFS, overall survival. Ross, a little bit of an existential question here. OS, is that the ultimate endpoint, or is PFS the be-all, end-all?
Well, it is, but we make many decisions in our lives that probably affect our overall survival. We don't, because they make us feel good in the short term. So I want to have a dessert later today. That's probably going to improve my immediate well-being, but my overall survival may not change. So I think overall survival, especially when we've got therapies that might keep people alive for years, has become so far removed from what we're doing immediately in the clinic that we have to have earlier efficacy endpoints, be they response rate, be they progression-free survival, be they CNS-related endpoints as well, which is not in your list here.
Sanjay, we look at toxicity. I think a lot of us are trained to hone in on that grade 3, 4, grade 5 toxicity and kind of ignore that first column. How do you look at the toxicity tables in that New England Journal paper?
Yeah, the grade 3, 4 is really important because, these are the peak events. But the peak events get better with dose reduction, at least with TKIs. So what you really have to look at is the grade 2s, because these are what people are living with on a day-to-day basis. If you're going to be living day-to-day for years, which many of our patients can achieve with these toxicities, then a chronic grade 2 becomes really quite problematic. And so you need to be able to counsel the patient, discuss that, and manage that toxicity in the right way.
Yeah, you can't really power through it. If it's chemotherapy, 4 cycles adjuvant, a lot of times patients will say, I can push through, I can finish this. Here we're talking about daily therapy, sometimes for years. And so we have to put those in the right perspective. Certainly cost factors in. And, we really do have an embarrassment of riches. We have so many options for a lot of these drivers. How do we choose, especially when we have a lot of good drugs? I think the best and hardest situation is ALK. Ross, I'm going to put you on the spot because you've written most of these papers. So give us a landscape of ALK and tell us how you choose what we should do. I think we have some data on the next slides too.
Yeah, one of the things we know that crizotinib, has an amazing place in history, but is beaten in multiple next-generation ALK inhibitors in head-to-head studies, beaten by alectinib, beaten by brigatinib, beaten by Insertion, and beaten by lorlatinib in direct head-to-head studies. Alectinib and brigatinib are essentially the same in terms of their efficacy. I tend to start with alectinib. I tend to keep brigatinib in reserve, even though that's not its label. And I think where we're coming, and Sanjay's point here, is lorlatinib is the new kid on the block. It probably may be the best in class. It certainly has a very good CNS penetration. In its head-to-head study against crizotinib, maybe it's going to turn out to have, the best in class progression-free survival, but it comes at a cost. And we now are in the world of oncology where if I, delay my time to the next treatment decision by 3 months or 4 months or 12 months, if I'm doing that at the cost of an extra 2 years on a drug which is less well tolerated, is that worth it in the big scheme, especially if I can't prove that I can't just play catch up later and use the less well tolerated drug as a next line therapy?
Alectinib was studied in the ALEX trial. Ross, I think you were involved in some of this data?
No, I was the US principal investigator, but thanks for remembering that. So the ALEX study was a head-to-head of alectinib versus crizotinib. It was the first drug to actually beat crizotinib in a head-to-head. It had a few other things. So knowing that crizotinib's liability was not getting into the brain, it allowed in untreated measurable CNS disease, and it certainly has shaped the idea of the brain as a battleground and getting good efficacy on that. It also mandated routine MRIs of the brain, not only in those with brain metastases, but also in those without. And you can see in the bottom right-hand corner, the lower blue line is actually the protective effect, the cumulative instance of new brain metastases being massively suppressed with the alectinib compared to the red line, which is crizotinib.
This led to the approval of alectinib, really a standard in the frontline setting, but it was joined by brigatinib in the ALPHA trial. Ross, I think you're familiar with this data as well?
Yeah, I was the principal investigator for this study. And this was, in the post-crizotinib setting, which doesn't exist anymore, brigatinib was like double the median PFS of alectinib. So we were so excited it was going to look awesome in the first-line setting. And it looked exactly the same as alectinib. And because it was about 2 or 3 years later, it's really struggled to gain a lot of market penetration because of that.
And Ross, can you talk us through some of the unique toxicity with brigatinib?
Well, generally speaking, it illustrates a couple of things. So its dose reduction rate in the clinical trials is 49%, and that sounds terrible. But they also did a similar study that the dose reduction rate in the real world is 15%. So what's the difference? Well, mostly in the study, there are rules where you have to dose reduce if something is a grade 3. And what happened was a lot of patients got grade 3 creatine phosphokinase, grade 3 amylase, grade 3 lipase, none of which had any symptoms. And in the real world, everyone ignores that. The other thing that maybe you're hinting at, Steve, is a very small proportion of patients, like 3%, will get what's called early onset pulmonary events. That means you start the pill and within 24, 48 hours, they will get short of breath. This was initially terrifying, Russian roulette, rare, serious, unpredictable side effect. It's now completely understandable. When we did detailed pulmonary function tests, almost everybody drops their DLCO by about 10 to 20% for a few days, and then it recovers with continued dosing of the drug. And most of those patients don't have symptoms. The 3% who have symptoms, who get the early onset pulmonary events, are probably the ones who don't tolerate a short-lived small drop in their DLCO. They've recently started an oxygen, recent pulmonary embolism, etc.
Now, you mentioned lorlatinib. This is sort of the newest phase 3 data, the CROWN study. These were updated to ACR this year. These are the initial data showing really a very impressive PFS hazard ratio. It's 0.28, numerically the lowest, although the confidence intervals do intersect with the other studies. This updated ACR earlier this year, the median PFS in this study still not yet reached, maybe tracking somewhere around the 5-year mark. We always say, use our best drug first. Numerically, this is the lowest hazard ratio. These KM curves, this is the widest separation. But Ross, you mentioned some specific toxicities, and shown there on the right are some of the data. Your experience with this drug and the toxicities you see?
So some people, it's like any drug, some people tolerate it just fine, but a significant proportion of patients, so 20% of patients will put on 20% of their body weight. 50% of patients will develop some kind of higher CNS cognitive disorder, memory issues, mood disorders, sleep disorders, hallucinations, auditory hallucinations. You can lessen it, as Sanjay said, by dropping the dose, but the fact that the dose reduction rate in the study is only 20% and these toxicities are higher, it means a lot of patients are ending up putting on a lot of weight and being a little crazy, and they're just putting up with it.
So certainly something we have to be aware of, but as you mentioned, if recognized early, hopefully we can make dose reductions an approved option in the frontline setting. I do want to be clear, but we do have many options here. ROS1 is a 1% alteration. There's another fusion that's relevant. Sanjay, can you talk about a little bit about some of the options for ROS1 lung cancer?
Yeah, we got some great options for it. We have the first data that came through with crizotinib. As we know, it hits ROS1 as well as ALK and MET. And, we see there's been several trials which have looked at this. One of the first registration studies showed a response rate of about 66%. We know it has a bit of a vulnerability in the brain, which is a problem with much of these oncogene-addicted tumors. And then the second drug that came along is Entrectinib. Entrectinib's an interesting drug, and it hits TRAC as well as ROS. So one of the problems that we're getting with entrectinib is that we see the on-target TRAC toxicities. And so we can get some neurological problems that it can cause. But, the response rate seems to be perhaps numerically larger, perhaps similar, depending on the type of study that we've seen out. But the progression-free survival of both of these drugs is really meaningful, and both, I think, are very reasonable options. They do have different toxicity profiles. We know crizotinib very well, some liver transaminitis, QT interval. Entrectinib has definitely a little bit more cardiac issues that we need to keep an eye on the left ventricle, especially for these younger, fitter patients that can be on this drug for a longer period of time. And of course, the TRAC on-target effects can be problematic for some patients. The new kid on the block, or at least coming around the corner for the block, is repotrectinib. So this is another TRAC ROS inhibitor, which has been given breakthrough designation status. So guys that are listening in the UK, do watch out, because breakthrough designation status means Project Orbis pathway for UK reimbursement. And this is a drug which is being evaluated both in the frontline ROS setting and in the post-TKI ROS setting, with some really very impressive results in that early data set as yet, and perhaps some TRAC data coming through down the line as well.
So a long list of available drugs for these different alterations. We're looking at response rate, but we're looking at PFS, OS, but in the context of toxicity. Another principle we look at when we're selecting these targeted agents is their efficacy in the brain, CNS considerations. And Marina, walk us a little bit about how you factor that in your choices.
Yeah, I think that also here we have a revolution. So we know that the previous generation EGFR tyrosine kinase inhibitors, they had some activity in the brain, because as you can see, the response rate was about 30-40%, although we know very well that in the clinical trials, sometimes the patients were pretreated with the radiation therapy, and so it was very difficult to understand what was exactly the response rate with the previous generation TKI. We know also that there is also some leptomeningeal activity, in particular with osimertinib, and doubling also the dose of osimertinib. But I believe that the big change was with the third generation EGFR tyrosine kinase inhibitor, because you can see that here with osimertinib, the activity and the penetration in the CNS is higher. And in my clinical practice, I think that in the beginning, I was treating the patient before with the radiation therapy in the brain, and then with the tyrosine kinase inhibitors. Now, with the results of osimertinib, I think that I'm doing exactly the opposite. In particular, if the patients are asymptomatic, I go and I decide also with the patient that maybe it is worth it to wait and start with the tyrosine kinase inhibitors, see the activity in the brain, and then just use the radiation in the end. Clearly, I suggest here to work in a multidisciplinary team and make the decisions all together, but the activity in the CNS is quite remarkable, and so this is something that we should consider. We know very well that from the results of the FLORA trial, and it was also seen also in other trials with the osimertinib, that the activity, the median progression-free survival of osimertinib was high also in patients with brain mets in the beginning. The median progression-free survival was 15.2 months. And you can see that from the curves, the osimertinib has had very higher activity compared to gefitinib and erlotinib and the first generation EGFR tyrosine kinase inhibitor. And what was, in my opinion, very important was that also the overall survival was superior of osimertinib compared to the standard of care. So I believe that it's still a problem to have a brain metastasis, but I think that maybe we have higher chances to treat these patients, and also this is the same also for all the other tyrosine kinase inhibitors, so for the ALK inhibitors, the RET inhibitors, and for all the other tyrosine kinase inhibitors. So I suggest you just to discuss every case with your multidisciplinary tumor board, and in particular, if the patients are asymptomatic, consider also the idea to start immediately with the tyrosine kinase inhibitors and then use the radiation therapy as a possible backup plan.
And we know this applies to other alterations as well. We have many CNS active drugs, and this really is a bit of a paradigm shift, but an important one, because there can be consequences with radiation. And we use a lot of stereotactic radiation here in the US, and we'll have patients that have 3 or 4 brain metastases. Maybe they see radiation oncology first, get SRS first, then come see us. We find a RET alteration, a RET fusion. We start them on a selective RET inhibitor, which we know is a great CNS active drug. And there are sometimes when I kind of regret that radiation. Ross, I'm seeing, at least it seems like a lot more radiation necrosis these days. Do you think that's true?
Yes, well, so there are multiple reasons for that. So one is, as we do more SRS, you kind of roll the dice every time, treat a single lesion. So as we treat more lesions, we have a greater chance that happens. Secondly, there's a time-dependent effect as your patient stays alive longer. They have enough time to manifest this. And then the third reason is we actually believe that some of these CNS penetrant drugs can influence the rate of radiation necrosis. We don't quite know why, but we are seeing radiation necrosis, I would say, much more in the presence of both immunotherapy and these CNS penetrant drugs. Whereas I saw it very infrequently, for example, when we just have crizotinib.
Yeah, and radiation necrosis can really be a devastating toxicity as well. It can be really challenging to overcome. So maybe in some cases, an advantage to really avoiding that. All right, principle 5 here. We have lots of options. We're thinking of CNS. We're thinking of response, toxicity. One thing that we see a lot, one of the challenges we have is acquired resistance. Sanjay, different types of resistance. How do you think of acquired resistance to targeted therapy?
Yeah, so I think it's really important that we work out what the resistance mechanism is for these drugs, because only through understanding the biological principles of resistance can we work out the best next steps for the patients that we have. And I generally classify them into these sort of categories that you can see on the screen. You have new mutations on the same target, and we will classify that as on-target mutations. Classic example being T790M in EGFR with a patient with a DEL19. You can have bypass signaling, so upregulation either through increased expression or through a gene rearrangement or through amplification or through a new mutation in another signaling pathway. Classic example being MET amplification. And you can have mutations in downstream effectors, so mutations in other parts of the same signaling system so that the same pathway is still activated despite the inhibition from the top down. And of course, the other thing that we notice when we biopsy our patients is that you can actually change or transdifferentiate the type of tumor that you have from an adenocarcinoma to a higher grade neuroendocrine carcinoma, or even sometimes a squamous cell carcinoma. And so these are the main mechanisms that we see.
And that last point I think is an important one, Sanjay, because you're not going to pick up lineage plasticity or small cell transformation necessarily with liquid biopsy. Right?
Yeah, and I think this is a big issue. So the problems that we have with liquid biopsy is that we're not very good at detecting gene copy number with liquid biopsy. Our bioinformatics aren't that good yet. So if we're relying on liquid biopsy to look for MET amplification, we're going to miss it. And if we are not biopsying our patients, there's no way we're going to pick up a high-grade neuroendocrine carcinoma. You can get some molecular variants that might indicate that it might be there, but really, unless you biopsy it, you don't know.
Now shown here is, as you alluded to, on-target resistance, a classic example here of T790M, and this was relevant at the time because we had an active drug in that setting. We know that for Osimertinib, it's a little different. So EGFR resistance is different from ALK resistance, but EGFR resistance is different based on what drug you're giving up front. And while T790M sort of mediates most of it for the first and second gen, it's really different for the third gen drugs. So when we think of resistance, we're thinking, is it one site versus multiple sites? We might think of local therapy like radiation or surgery if it's just one site. Clearly, if it's a lot, we need better systemic treatment. Our general approach, if there's something targetable, maybe we can target it versus switching completely. And there are certainly mechanism agnostic strategies. So let's talk a little bit about resistance to frontline Osimertinib. We hear a lot about MET amplification. Ross talked about the qualifications of how we define amplification, but this is something that's potentially actionable, as well as other fusions. And so, Ross, how can we see RET and EGFR? Does this happen in practice?
Yeah, so all our basic principles that these things are mutually exclusive get exploded when we're talking about the acquired resistance setting. So as Sanjay said, you have on-target and off-target resistance. And on off-target, just think of anything that can be a driver can come back in as a co-driver. And so we see these things. And the great thing is some of these things are targetable. There may be a drug company telling you to combine a RET inhibitor with osimertinib when you get RET fusion, but you can see from Zosha Piotrowski's paper here that they do respond.
So great responses here with both selpercatinib and pralsetinib adding the RET inhibitor to these two cases. MET is also potentially actionable, right, Ross?
Yeah. Again, if you have a MET exon 14 skip mutation or a MET gene fusion, that's fine. But MET amplification, the issue is what level do you call relevant? It may appear somewhat different as a primary driver than in the acquired resistance setting. And the simplest way to understand that is it's a subclone. And so your denominator is all of the cancer, whereas your numerator is just the resistant clones. But you can see here osimertinib plus savolitinib in a slightly messy study because you could be MET positive in a whole bunch of different ways using local testing. And also you didn't have to have had a third generation inhibitor to go into the study. So what was the osimertinib effect as well? But you can see, I think it's in the left-hand column B1, previously treated with a third generation inhibitor. They got a reasonable 30% response rate here. Other studies, maybe you're going to go into those, using different and slightly more robust means of defining MET amplification as the mechanism of resistance, have produced higher response rates.
And these are some data we just saw. I know you saw these, Ross, because you were sitting right next to me. We heard about amivantamab before. What do you think of these data?
Well, so this I took away in two different ways. So here we are with our amivantamab, our bispecific EGFR MET antibody. You progressed on a third generation inhibitor, and then you went on to lazertinib, so Janssen's third generation inhibitor plus amivantamab. Because you were going third generation to third generation, that shouldn't have been an issue. In the data that was presented here, you could have had intervening chemo, but they had another study that looked very similar results when there wasn't intervening chemo.
So lazertinib, not an approved drug now, an investigational third-gen TKI, but amivantamab showing clear activity after osimertinib, may be able to overcome resistance in certain patients after osimertinib. So we will have more options. And there are some that do seem to be a little independent of mechanism. Marina, can you talk to us about Petritomab?
Yeah, I'm sure that you saw in ASCO a lot of antibody-drug conjugates. This is one of them. This is Petritomab deruxtecan. Petritomab is targeting Her2, which is overexpressed in lung cancer in about 80% of cases, in particular in cases with EGFR mutations. And you can see that there was a very good activity with a response rate of about 40%. And what you can see in the bottom of the slides is that the majority of patients responded independently by the mechanism of resistance. So the progression-free survival was, again, pretty remarkable, 8.2 months. And so I believe that this can be really a nice strategy for the future of our patients.
Yeah, we need strategies to overcome resistance, some that can be targeted to specific subsets, some that sort of work a little more globally. You mentioned TRAC. Sanjay, TRAC inhibitors really are approved now for patients with NTRK fusions, not mutations. We have larotrectinib and entrectinib both approved in the frontline setting. While these are very good drugs, they're very active, we do see resistance. Luckily, we do have some next-gen TRAC TKIs that are in development, repotrectinib, selitrectinib, and taletrectinib, all with early data. None of these drugs approved yet. Repotrectinib is a type 1 macrocyclic kinase inhibitor that should be designed to solve front and gatekeeper mutations. Really, targeted therapy is the playground for medicinal chemistry. And really, all these drugs are the result of very active medicinal chemists. When we think of resistance, these gatekeeper mutations and solvent-front mutations can really prevent these oversized type 1 TKIs from gaining access to that ATP binding pocket. What we see is that these new macrocyclic kinases, they're smaller, they're compactor, and they can still get in and have an effect. The Trident study is an early stage study looking at repotrectinib in two sets, ROS1, which you'd mentioned, Sanjay, and NTRK fusion. It does have activity at both. For ROS1, we saw in the frontline setting, overall response rate there, 79%. In patients who had prior ROS1 TKI and prior chemotherapy, response rate 42%. If we look at those with a solvent-front mutation at G2032R mutation, that response rate 59%. So maybe we should be selective, but really encouraging responses in these settings. This drug not yet approved. But in NTRK, TKI naive, we saw response rate 41%, and those pre-treated, we also saw activity. Here, response rate 48%. Preliminary efficacy, these are the waterfall plots. For those that are new to these types of images, each of these bars represents one patient, and 0 is where you start. And so if it goes up, your tumor grew as the best response. If it goes down, your tumor shrunk. We see this has the familiar look, a waterfall plot that we want to see with targeted therapy, where most patients are getting a response. That was NTRK. Here's ROS1. where again, the vast majority of patients seeing some reduction in their tumor, and we'll see if this drug becomes available. So addressing therapeutic resistance, we're really going to pursue biopsy, biomarker profiling, looking for something we can act on. Fortunately, in some cases, we do have a next-gen TKI. Chemotherapy, though, remains an effective treatment. And, Ross, you published a little data on chemotherapy and certain drivers. These are active drugs still, right?
Yeah. I mean, we know that all of the gene rearrangements have exaggerated sensitivity to pemetrexed. And the big debate, as you have it there, is when you progress on the TKI and you start chemotherapy, do you keep the TKI going or not? We had previous studies with first-generation EGFR inhibitors that said there was no real advantage. But in the setting of drugs that now get into the brain, would you be taking away protection of the brain? There are attempting to replicate these studies with modern TKIs, although they're hard to accrue to because patients actually don't want to be in the arm that stops the TKI.
Yeah, so very often we will continue, but acknowledging the lack of prospective data so far. Immunotherapy, though, maybe a little less appealing. Marina, do you use immunotherapy in someone that's progressing on an EGFR inhibitor?
No, we are still waiting for the results of the combination of chemotherapy, immunotherapy, and also the anti-angiogenics, but I don't suggest to use the immunotherapy alone in this category of patients, and in general in all the target mutations.
And that's different, right? Because we use immunotherapy for everything, but this is a case where it really hasn't been effective. These are different cancers. So driver positive lung cancer is a different cancer, different biology. We're now treating it differently. We've shown data up to date here on late stage, but these same principles probably apply to early stage as well. And we saw some of these data relatively recently in that early stage. Sanjay, can you talk us a little bit about ADAURA?
Yeah, so ADAURA is, in my mind, one of the most important trials in the history of lung cancer development. Ross, for your book at some stage. So ADAURA is a really critical study. It took patients with EGFR mutation. We know that the EGFR mutation can be highly effectively drugged in the metastatic setting. So can we translate these findings to the early setting? We've had previous studies with first and second generation inhibitors, perhaps not that much activity and some controversies about where patients relapse. Now you've got a highly effective brain penetrant drug. Does it reduce the rate of relapse? So ADAURA was randomized phase 3 double-blind study, patients with operable disease, stage 1B, 2, 3A, in patients that had undergone cancer-specific surgery. They all had adjuvant chemotherapy or not adjuvant chemotherapy as patients and oncologists decided, and were randomized to 3 years of osimertinib or placebo with the primary endpoint of disease-free recurrence rate. And what we see is a bunch of hazard ratios that are unheard of in lung cancer. I mean, in lung cancer, we love great hazard ratios, and we've got very embarrassed by our riches of wonderful hazard ratios about 0.6, very excited by that. But, here we've got in the stage 2 to 3A, which is the primary endpoint, hazard ratio 0.17. I mean, I had to look at that a couple of times before I could really make sense of that. I mean, these are phenomenal differences. And then if you add in the 1Bs as well, you get 0.20. So what we're seeing is at the 2-year and 3-year time points, the vast majority of patients that are on osimertinib have still not relapsed. Now, there are a number of caveats to this. This isn't the final data. This is a first interim analysis. And the problem with the first interim analysis is we don't know whether this data will mature and still be as good as it is at this point. Of course, we're skeptical that it will be as good because historically, early interim analyses have never outplayed the later analyses. And these are the overall survival. I mean, at the moment, we've got so much censoring, it's almost impossible to make any head or tail of the censoring of the overall survival data.
But Sanjay, if you're showing me a DFS hazard ratio of 0.17, an 83% reduction in the risk of disease recurrence, one thinks that is likely to translate to OS, but Marina, not necessarily, right? We have a little bit of track record here.
Yeah, we had previously some trials that were negative for the overall survival. This is one of them. And this was a comparison also with gefitinib and the chemotherapy, but there was another trial that was the Radiant trial with erlotinib, and they failed to show an increase of the overall survival. There was a big debate behind that, and one part maybe could be that the fact that the tyrosine kinase inhibitors were given just for 2 years or 1 year and not for 3 years like in osimertinib. So I come from Europe and I'm a fan of the overall survival, but clearly the results of the ADAURA were quite impressive. Also, if we had also negative trials in terms of overall survival.
So jury's still out a little bit, but the drug is approved by the FDA for use in adjuvant EGFR mutant lung cancer. When we think of resected EGFR mutant lung cancer, Ross, do we still need to give chemo?
Well, I mean, this is controversial. So there's at least one of my colleagues who says, well, you have this amazing disease-free survival advantage, and you're going to get like a 5% overall survival advantage with chemotherapy and lots of toxicity. Why give it? My argument would be because it has a 5% overall survival advantage, and the issue with the disease-free survival, I personally don't think it's about the 1 or 2 years. It's about doing the analysis when most of the people are actually on the therapy. So 60% of the people in that ADORA analysis were on therapy when they did the analysis. So you're really looking at, does a TKI suppress disease versus nothing? If you did that study in the metastatic disease and you did the analysis of placebo versus osimertinib after a few months, you'd have the same hazard ratio, seriously. So the issue is twofold. One, will it change overall survival? I do not believe it will. I think those curves will come back together as the drug stops. But the second question is, does that matter that it doesn't change overall survival? And the purest view is, no, it doesn't. We should only use adjuvant therapy if it changes overall survival, just like we argued with adjuvant chemotherapy. But I've actually changed my thinking on that. If I told you that you could get in a time machine and come out and in 5 years' time, and then we'll treat your cancer, given the speed of change that we've seen, maybe everything's going to be better. So I start to view adjuvant TKIs not as a means of curing the patient, but as an oncology time machine.
Okay, hold on. Let me push on that a little bit then. So Ross, you see a resected 3A, microscopic 3A lung cancer, but with an ALK rearrangement. Are you thinking adjuvant ALK therapy there?
Not in the absence of a license, but I mean, it's going to look exactly the same.
We also are exploring these in the neoadjuvant setting. I think this brings up different questions about should neoadjuvant therapy affect the extent of surgery? Really difficult questions to answer, but we have the NeoAdora study, which is looking at osimertinib as part of neoadjuvant therapy with chemo or on its own. We have the ADORA 2 trial, which is looking at the role of adjuvant TKIs in stage 1A lung cancer, and the LCMC4 leader trial. This is really looking at a bunch of different targets in that neoadjuvant setting. So we'll have more answers to come. Let's talk a little bit about some of the non-TKI targeted therapy options. Targeted therapy, we're usually talking about kinase inhibitors, but there are other options, monoclonals, bispecifics, ADCs, different combinations. This is one of my favorite alterations, one of the rarest, though. I acknowledge that it's hard to find, although we've seen 2 in the past 2 weeks at my institution. Neoangular-1 fusions are rare events. They occur in about 0.2%, but they're across cancer. So we see them in lung cancer. You see them in breast cancer, colon, cholangio, sarcoma, GBMs. These are best detected with RNA-seq. And what you had said, Ross, earlier, this is a huge gene. It's a massive gene. Almost all of it is intronic. And so if you're doing DNA-based NGS, you are not going to get the coverage to find these. If you splice out those introns and with RNA-seq, then you are much more likely to find them when they're there. And what we saw in a registry study is that they do relatively poorly with chemotherapy and chemo IO. We do have some drugs in development for NRG1 fusion positive lung cancer. Afatinib, we know, is a second-gen pan-ERB kinase inhibitor. This drug has activity. Shown here are some case reports, a case series showing that afatinib can induce responses, some of which can be durable. And the reason why we see afatinib work, if you look at that cartoon on the right, NRG1 is not the kinase. NRG1 is the ligand. It's that little red ball there. And so what happens is NRG1 normally binds to HER3. When you have a fusion, instead of NRG1 floating around, it is tethered to the cell membrane in proximity to that receptor. And so it is inappropriately close to its receptor and constantly binding. It binds to HER3. HER3 heterodimerizes to HER2, and then you see downstream signal transduction. While we don't have a drug targeting the NRG1 ligand, we have lots of stuff that targets HER2, like afatinib, and we do see case reports here where we see activity. The TAPER trial is ASCO's prospective study. This has an arm for NRG1 fusion cancers, all types, where afatinib is given. BI also has a decentralized prospective study of afatinib, where they provide afatinib in single patient INDs for anyone with an NRG1 fusion positive cancer. So afatinib will get some prospective data here. Zenocutuzumab is a bispecific antibody that targets HER2 and HER3. This has shown some impressive data. These were data presented last year, 76% with some reduction. And this year at ASCO on Tuesday in the developmental therapeutics, we'll see Seribantumab. This is an elevation antibody, a HER3 monoclonal antibody that's being studied in the Crestone study in different tumors with NRG1 fusions. And we'll see those exciting data on Tuesday at this meeting. We also have other targets, other types of treatments that can be effective in targeted therapy, like antibody drug conjugates. Marina, can you walk us through some of those?
Yes, so as you can see, the antibody drug conjugates are done by more or less three parts. One part is the antibody, and we have many of them, then we will see the targets. Then there is a linker and a payload, which is basically a cytotoxic drug. So basically with one part, you can stay on the tumor, and with the other part, you can deliver in a more clever way the chemotherapy. There are many targets. I'm sure that you have seen them in many presentations in ASCO, and you can see that the targets of the antibody drug conjugates in the pipelines of the pharma companies are many. We saw Her2, Her3, TROP2, CEACAM5, c-MET, and also for small cell lung cancer, DLL3 is quite has a remarkable activity, and also TROP2. So I think that potentially and hopefully they will become part of our armamentarium for the treatment of advanced non-small cell lung cancer, and basically also for small cell lung cancer. This is one of them. We will see the results tomorrow. This is an antibody drug conjugate targeting CEACAM5, and the CEACAM5 is expressed in about 25% of the non-small cell lung cancer patients. And tomorrow you will see the results that are quite impressive. They are clearly just 11 patients, but the response rate was very high, and in particular in this subpopulation, the patients were highly pretreated. They were third and fourth line. So hopefully we will see this type of new molecules more often in the pipelines and also in the future of our patients.
And we talked a little bit about MET, and you'd mentioned, Ross, that MET IHC will be relevant. This is the reason why. This is a drug with breakthrough designation. Can you talk a little bit about Teliso-V?
Yeah, so, I mean, MET gets complex because when you have protein expression, is that just on a normal non-small cell lung cancer without a driver that's related to MET? Or is it also coexisting with one of these MET drivers? But either way, Teliso-V is a MET-directed ADC in patients who were non-squamous EGFR wild type and were pre-selected for MET protein expression which represents about 25% of that population. They had a very good response rate. Then if they broke that down by the high MET, so that's now about 12% of lung cancer, they had a quite astonishing nearly 54% response rate. Because MET, as we heard earlier, is also a mechanism resistance in EGFR mutant lung cancer, there's a separate subgroup looking in combination with an EGFR TKI in EGFR mutant lung cancer. And you can see down at the bottom from the abstract that Jonathan Goldman's going to present, response rate of nearly 60%. I mean, it's just amazing.
Really exciting drugs here. Another ADC that's getting a lot of attention, though, is targeting HER2. And Sanjay, I'll ask you to walk us through a little bit of the HER2 ADCs.
Yeah, so HER2 is a druggable target in lung cancer. We've been really looking at what the target is in lung cancer for a while. It's not very clear because we have the same problem as MET. Is it the protein, is it the copy number of the gene, or is it the mutation? And certainly at the moment, we're very much currently focusing on the mutation as the particular target, which is a bit paradoxical because the drug that actually seems to be having the greatest activity is something that affects the protein on the cell surface. Where we are depositing the toxic payload, the chemotherapy agent on the cell surface. But this seems to be having an effect not only on the cancer cell directly, but also via targeting the bystander cells, which then affect the tumor cells. Now, we've had data previously on TDM1, which our breast colleagues have been using for some time. I would suggest that there is activity there, but relatively modest activity there. And the trial that I think is going to revolutionize this space is the Destiny Lung 01 trial, which is presented by our colleague Bob Lee from Memorial previously. And this is a multi-cohort expansion, dose escalation and cohort expansion in different cohorts. But, we've got an overexpressing cohort and a HER2 mutation cohort with the drug trastuzumab deruxtecan. So trastuzumab is the actual parent antibody, which binds to the HER2 protein. And deruxtecan is the toxic payload which is delivered, which is essentially a cytotoxic. And when we look at the data with Destiny Lung 01, this is the HER2 mutant cohort expansion, what we can see this beautiful waterfall plot, a plot that, we just love to look at, with amazing shrinkage in the vast majority of patients. And even when you look at these spider plots in the bottom part of the graph, you can see the vast majority of patients are getting some shrinkage, which is durable. If you look at the interesting part of the bottom of the waterfall plot, even some patients with no expression of HER2 are getting some sort of shrinkage, which I think is part of the beauty of these ADCs. Now, when we look at the safety, there are a number of things we need to consider. Yes, this is an ADC, so chemo light is what I sort of describe it to my patients. Very light, depending on what dose we're giving. But we do see some unique toxicities. And this particular compound, the deruxtecan, can cause ILD-like pneumonitis in patients, which in this trial occurred at about 26%. Is that a big deal? Well, look, we're pulmonary oncologists, right? We deal with pneumonitis on a day-to-day basis. So, for me, I don't think that's such a big a deal. It may be a bigger deal for oncologists that aren't lung docs that are dealing with this, where pneumonitis is relatively rare. And if we look at where we've got some activity that the drug has in the HER2 overexpressed data set, it's not perhaps as impressive as we've seen with the mutation. That probably speaks to the biology, that HER2 expression is not necessarily a key driver here, and they were getting more passenger efficacy than we are really driver efficacy that we're seeing here. But nevertheless, this is still potentially important efficacy data that we are generating. And we should look out for this trial, which is currently launched, the Destiny Lung 04 trial, in which patients with HER2 exon 19 or 20 mutant lung cancer are randomized in the first-line setting, either to the standard of care chemo-IO, pembrolizumab, pemetrexed, or T-DXd at the 5.4 dose, slightly lower dose with appreciable efficacy, but certainly less risk of pneumonitis.
Now, this drug not yet approved by the FDA for lung cancer, but is available for other cancers, and it is in the NCCN guidelines, which can help us sometimes get that offered for patients with HER2 mutant lung cancer. Marini, you talked a little bit about Petritomab. Can you walk us through some of these data?
Yeah, this is just an update of what we saw before. And this is an antibody drug conjugate which targets HER3 that, as I said before, is overexpressed in about 80% of lung cancer tumors. And as you remember, the response rate was pretty interesting. It's about 40% with a median follow-up, with a median progression-free survival of 8.2 months. And there is, again, some ILD toxicity. And I'm sure that in the future, we will be able to manage also the ILD toxicity. The results that were presented last year, and they are updated also in ASCO this year, they showed, again, a pretty interesting response rate with a very good progression-free survival.
The last topic today is TROP2, with 2 TROP2 targeting antibody drug conjugates in development. TROP2 is a transmembrane glycoprotein that is highly expressed in non-small cell lung cancer. We detect this by immunohistochemistry, shown here at the bottom right. No current testing recommendations because there's a very high prevalence of TROP2 expression in advanced non-small cell lung cancer. What we do know is that high TROP2 expression is associated with a poor prognosis, as shown in the Kaplan-Meier on the top right. We have 2 TROP2 targeting antibody drug conjugates in the clinic being explored in lung cancer. The first is sacituzumab govitecan. As with all ADCs, there are 3 components. The payload for this is SN38. That's a more potent version of irinotecan, a topoisomerase 1 inhibitor. It is linked using a hydrolyzable linker with a very high drug-to-antibody ratio, 7.6 to 1, to a humanized anti-TROP2 antibody. And that provides the targeting, directing this compound to the cells of interest. Sacituzumab govitecan has clear activity in metastatic non-small cell lung cancer. We saw a response rate about 17%, median survival 9.5 months, but this was a very heavily pretreated population with almost 60% of patients receiving 3 or more prior lines of therapy. As we move earlier in therapy, we really expect those numbers to go up. Importantly, sacituzumab govitecan had a very manageable safety profile in the early phase 1-2 studies. The ongoing trials will tell us a lot more about real efficacy in an earlier population. The EVOKE-1 trial is a randomized phase 3 trial comparing sacituzumab govitecan to docetaxel. That's going to be after chemo and after immunotherapy. And the EVOKE-2 trial is a first-line study that looks at the combination of sacituzumab govitecan with PD-1 immunotherapy and with or without chemotherapy. So more to come on sacituzumab govitecan. We have datopotamab deruxtecan also being explored in this space. This has a slightly lower drug-to-antibody ratio of about 4, but the anti-TROP2 linked through a stable linker payload to deruxtecan, and that's a cleavable tetrapeptide-based linker, another topo-1 inhibitor. We learned about this drug in the Tropion pan-tumor 1 study. It looked across different tumors, but the expansion in non-small cell lung cancer looked at 4, 6, and 8 milligrams per kilogram. What we saw was pretty clear activity with response rates hovering around 25%, duration of response 9 to 10 months in the 6 to 8 mg per kg dose. Very clear activity as shown in the waterfall and the spider plots on the right, really regardless of doses, seeing impressive responses. An interesting feature of datopotamab deruxtecan is its activity in driver-positive lung cancer. And so when we look at tumors with actionable genomic alterations, that's an area where we have a huge unmet need. We saw response rates in this set of 35%, duration of response 9.5 months. I'll call out clinical activity specifically in EGFR mutant lung cancer after osimertinib. The reason this is important is these are generally tumors that don't respond to immunotherapy and those types of strategies, and really the only option being chemotherapy that's providing a very important option in that subgroup. If we see more, we will learn more from ongoing studies. Again, the Tropion pan-tumor 1 study showed that we see activity across doses. The 6 mg per kg dose is the one that's been selected for further development, where we saw a response for the 28%, median duration of response of 10.5 months, and safety profile, very manageable, but watch for things like nausea and stomatitis. Tropion Lung 01 is ongoing based on these results. And we have Tropion Lung 05 that's looking specifically in patients with lung cancer that has an actionable genomic alteration after targeted therapy, after chemotherapy. Again, huge unmet need. We'll see how active datopotamab deruxtecan is in EGFR, ALK, ROS1, RET, MET positive lung cancer, as well as others. So TROP2, hopefully an interesting case. We're going to go through this case very quickly. 75-year-old female, never smoker, diagnosed with EGFR wild type lung cancer. NGS does show mutations in STK11, ARID1A, TP53, and ERBB2. She receives carbo-pembro from December 2019 to February 2020, then pembro alone until May 2020, but then has this PET scan progression in the superclav, left hilar, left adrenal mets, nothing on Guardant. When we think of different options here, out of these ADCs, what are we going to recommend for this patient? Trastuzumab deruxtecan, TDM1, Petritomab deruxtecan, datopotamab, we call it data potato. We do know that Her2 mutations do predict response to the trastuzumab deruxtecan ADC, and so this was a very active drug. But now imaging suspicious of ILD. Ross, how do you manage ILD after an ADC?
That's a great question. So I'm going to disagree with my colleague Sanjay because that's fun to do. But I do actually think ILD is a big issue. So if you catch it when it's grade 1, so that's asymptomatic radiographic changes, you can hold the drug, start steroids, and probably when it settles in, you can cautiously reintroduce the drug. Maybe you're going to even reintroduce it with steroid coverage and taper off the steroids. Once you get into grade 2, which is when you start to have symptoms, or grade 3, when you need oxygen, well, you become into a problem because it really is a snowball effect. The kind of, the cat is out of the bag at that point in time. And yeah, maybe not everybody dies, but a lot of patients end up on the intensive care unit. So the key thing, I think what we'll find in the future is that so as soon as you start steroids, grade 1 becomes grade 2. So you'll see the grade 1 rate go down, the grade 2 rate go up, and the grade 3 and 4 rate go down, because we'll start steroids earlier. And that's what I think the management of ILD will be in the future. Spotting it early, holding, giving steroids, settling it down, cautiously reintroducing.
We have a few questions that I want to go very quickly. These are rapid questions. Sanjay, difference between ctDNA and cfDNA?
So circulating free DNA is the total amount of DNA short fragments which are identified in the plasma, only of which a small proportion arises from the tumor, and that small proportion is called circulating tumor DNA.
Ross, here's a great question. Exon 20 insertion treated with chemo IO at first line, progression after 15 months, then mobocertinib, and then progresses in the brain, innumerable brain mets, mild systemic progression, already received brain radiation. Question here, any role for osimertinib in exon 20 insertion lung cancer?
So the usual answer should be no, but it all depends on which exon 20 insertion you've got. So there's some rare ones which are actually responsive, but let's assume you don't have one of those. You can try it. You can even try high dose, but I would be very pessimistic that it's going to do anything. I think that's a bad situation for the patient, unfortunately.
And here's another quick question. KRAS G12D, what's your management there, Marina?
So, well, as we said before, G12D is different from the G12C. And so there is no activity of the two drugs that we saw before, but there are already in the pipelines of the pharma companies many KRAS inhibitors coming. So if you have a patient with a G12D, maybe you can refer these patients to centers where they have the clinical trials, and tomorrow we will see also some results on them.
We're at time. If there are other questions, we're happy to stay a little longer and ask, but I want to be respectful of your evenings. Thank you so much for coming, and really thank you to the panel here. It's been an honor. I love learning from all of you, Dr. Garasino, Dr. Kamich, Dr. Popat. Let's thank our panelists for coming, and again, thank you guys for joining us.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/UTP860. This activity is supported by educational grants from Daiichi Sankyo Incorporated, Elevation Oncology Incorporated, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, Sanofi, and Turning Point Therapeutics Incorporated.